Okay, now regarding appendicitis investigations, we start first of all with the blood, then urine, then radiologic. Okay, so we are starting with the CBC. Most sensitive is increased WBCs, mainly with a left shift. فمعناتها بيكون عندنا polymorph nucleic cells اعلى بكثير، وغالبا sensitivity تزداد اذا كانت اكثر من 16000. عندي CRB مرتفع اذا كان اكثر من 10. This is highly sensitive and this is actually derived from the guidelines. فعندي RFT، عندي pre-renal azotemia because of the dehydration. لان ايش قلنا في clinical presentation؟ قلنا المريض ممكن يجيني بنازيا، ممكن يجيني vomiting. طيب وممكن يجيني لا قدر الله obstruction correlated with the appendicitis، يعني يصير عندي paralytic ileus مع الابنديسايتس اللي المريض جايني فيه. طيب any female we need to rule out pregnancy. ايش هو التست حق البريجنسي؟ اللي هو البيتا HCG. urinalysis pre-operatively and because of this dysuria، لان نفس ما قلنا في الكلينيكال برزنتيشن and the physical examination ممكن يكون عندي dysuria correlated with pelvic appendix. طيب leading to dysuria، وعشان to rule out انه في عندي UTI ولا لا اسوي له urine analysis. طيب now regarding radiologic investigations، في عندي اول شيء الريكت abdominal X-ray. في عندي the best initial، this is regarding the questions في الإكزام و regarding the rotation questions. best initial imaging اللي هو الالتراساوند. best diagnostic imaging اللي هو CT with contrast actually if it was indicated. in clinical practice if it was indicated. in the exams the best diagnostic imaging was CT with contrast. However, in the rotation if asked about what is the best way for definitive diagnosis, it is surgical visualization of the appendix, in which these are the indications of CT and the reason why they are indicated. في الفيميل because it mimics tube ovarian disease. نفس ما قلنا في differential diagnosis قبل، قلنا pelvic inflammatory diseases other causes of tube ovarian diseases. في عندي delayed or equivocal presentation. ماني عارف هل هو المريض هذا appendicitis ولا ما هو appendicitis، او انه presenting to me generally with generalized abdominal pain. okay، والphysical examination حقه not tilting towards a specific خلينا نقول pathology that is correlated with an acute abdomen. الهيستوري حقه ما في حاجه specific that is tilting towards one differential rather than the other. This is where the role of CT with contrast comes handy. An elder patient, why? Because as we said, we have the risk of a cecal mass presentation and a cecal carcinoma. Okay. Now, regarding what are we going to see? Okay, أنا سويت له الأشياء. إيش حشوف؟ في الأبدومينال إكس-راي حقيقة بنشوف حاجات non-specific، ما في حاجة specific to say إنه this is appendicitis or not. However, في الالتراساوند في عندنا it is more than 6 mm in diameter with high vascularity. Okay, they call highly vascular. إن شاء الله بنشوف الصور بعد شوية، ولكن I just wanted to keep in mind that it is more than 6 mm with high vascularity if we change it to Doppler. طيب CT عندنا more than 6 mm also in diameter with wall thickening more than 2 mm with periappendicular fat stranding and periappendicular fluid formation, free fluid as said. Surgically you're going to see an erythematous, dilated and congested appendix. وبإذن الله راح نمر على كل واحدة من ultrasound, CT والsurgery, mentioning a few points about each one of them. And this is the recommendation regarding pregnant ladies. The best modality is MRI. However, the best initial modality is ultrasound. طيب, as we can see نبدأ هنا من الإكس-راي. طيب, on the right you can see that we have obvious and erect abdominal X-ray in which we see peding, and we can see that we have an air fluid level with absence of the rectal gas, which are non-specific signs for appendicitis. This patient is an appendicitis patient that is presenting with several signs that are not correlated with the appendicitis per se. However, on the other side, we can see the ultrasound. You can see the Doppler in here. It is highly vascular. You can see below it, you can see how the wall thickness is increased. You can see that it is dilated. You can see we have the presence of a hypoechoic margins here, okay, that may indicate the presence of periappendicular free fluid. Now regarding the CT, on the top right corner in the red arrow, you can see that we have obvious fat stranding around the appendix. Below it, you can see the presence of a feculate, which is very obvious here from the black arrow. And you can see here the diameter of the appendix 17 millimeter, which is very, very obvious that it is dilated, it is thickened, and it is inflamed. And in here, this is not usually seen, as we previously mentioned, that in the X-ray we had a radio-opaque mass at the appendix anatomical location, which might indicate the presence of an appendicolith. Now regarding the diagnosis. The diagnosis of appendicitis is a clinical diagnosis. This is why, for the sake of easing up this process of diagnosis for primary healthcare physicians, the Alvarado score has been developed. Okay, it has been developed to help primary physicians diagnose appendicitis by history and physical examination and CBC. Okay, in which we see that the components is migration of the pain, as we mentioned, anorexia, nausea, tenderness too, because it is sensitive, and rebound tenderness, rebound pain. We've got the elevated temperature, we've got leukocytosis, as you see, because it is sensitive, with a left shift. 7 or more in most hospitals. If you see 7 or more Alvarado score, tell your senior that this patient is most likely an appendicitis patient with a predictability of 93%. And this is a statement from the guidelines showing that the combination between a proper history and examination with ultrasound has a high sensitivity and specificity for appendicitis.